Good evening, one and all. I welcome you all to today's Navigate Medico CME program. I invite Professor Umesh Kapil sir, the Secretary of National Academy of Medical Sciences, to deliver the welcome address.
Good evening to all, and my most humble respect and regards to all the eminent speakers, and speaker particularly Dr. Velu Nair, who is AVMS, BSMS, and Group Head, Medical Services and Chief Consultants, Hemato-Oncology and Bone Marrow Transplant at Apollo Hospital, Gandhinagar. It's a rare privilege to listen to him, and he will be talking about venous thrombosis and embolism. And he is one of the outstanding clinicians who have been working in the actual real life situation. It's very difficult to get him on phone because quite a good number of time he's examining the patient, and we are fortunate to have Dr. Velu Nair with us, and his words of wisdom are always welcomed by the National Academy of Medical Sciences. And sir, we are most grateful to you for accepting our offer and to be with us for this Navigate program. We are gradually picking it up, and every good thing takes time.
Yes.
And gradually we feel that it will pick up fast. And we do have two more channels, like it's a live telecast on YouTube, which makes it that about 150, 200 people, they join on the YouTube. And second is, what we have is all the lectures and all the PowerPoint presentations, we put it on the NAMS website, and we have made an e-library. So all the Navigate lectures which have been taken till date have been put on the e-library so that the MD students, the DNB students, they can join and they can listen to you for all time to come. So this is a humble beginning which we have done. And again, my most sincere thanks to you and to dear Preeti for helping us out for all the efforts which we are doing in the Navigate program. I must say that this is a humble effort, but it is very important. We hope that we are going to have more success in coming months. Thank you very much, sir. Welcome, Alex. Thank you.
Thank you, Doctor.
Now I would like to invite Professor Lieutenant General Velu Nair sir, who is the Group Head of Medical Services and Chief Consultant at Hematology and Bone Marrow Transplantation at Apollo. He is also the Chairman of Nuclear Accident Management Committee, Asia Pacific Blood and Marrow Transplantation. He is also the Chairman of Scientific Advisory Committee of National Institute of Virology, Pune, and National Institute of Immunohematology at ICMR in Mumbai. Sir was formerly the Director General of Medical Services, Army. He was the Dean of AFMC Pune and Army College of Medical Sciences, New Delhi. He had been the President's Honorary Surgeon, President of the National Society of Hematology and Transfusion Medicine, and President of the Delhi Society of Hematology. He has been awarded the highest peacetime award of the Armed Forces, Param Visist Seva Medal for distinguished services. He is also the recipient of Ati Visist Seva Medal, Visist Seva Medal twice, and 20 other award of eminence, including Major General Amir Chand Award. He pioneered the setting up of the first Department of Clinical Hematology and Bone Marrow Transplantation in Army Hospital, Delhi, and 5 other centers in the Armed Forces. He is a leading hematology oncologist with over 30 years of experience in bone marrow transplantation and hematology, with significant experience in treating adult and pediatric patients with various blood cancers and other blood disorders. A teacher of eminence and avid researcher with over 25 years of teaching experience in medicine and hematology, who is a teacher and examiner for MBBS, MD, and DNB medicine, DM clinical hematology, and PhD in various universities in the country. He was awarded the NBE Teacher Award for Excellence in Medical Education in 2014. He has also published 252 international and national journals, and he is also the editor-in-chief of 3 books and several chapters. It is an honor to have you here, sir. Over to you, sir, for the conduct for today's session.
Thank you, Dr. Preeti. Can we share the slides, please? Is my screen visible?
Yes, sir, but it's not in full screen mode.
It's in full screen now.
It is full screen, sir.
Yeah, yeah. You can see it?
Yes, sir. Yes.
Yeah, yeah. Okay. Okay. ये minimize कर दो इसको. Yes. First of all, I must say it's an honor and a privilege to be able to give this talk today for the National Virtual Graduated Medical CME, also abbreviated called as Navigate Medico CME. I must congratulate our President, Dr. S.K. Sareen, our Secretary NAMS, Dr. Kapil, and Dr. Sood, and now Preeti is also completes the team, who have actually really made this possible with the rest of the NAMS team and obviously the other, members of the National Academy. And I think this goes a long way because they've got the best people in the country to come and actually conduct these series, which are, domain specific, organ specific, system specific. And I think you can't get it better all in one place. And they're doing it serially on Tuesdays, Thursdays, and Saturdays. And I thought it was a great idea. I'm sure it'll, sort of have a cascading effect. More and more people will join us. And I'm sure today also we have our students from MD, MS, DNB, some DM students all joining us. And this series on common hematological disorders was started on the 1st. We had a lovely talk on anemia by Dr. Abe Bhave on the 1st. I'm giving the second one on thrombosis. And the third one will be on thrombocytopenia in the critical care setting. So for this, I'll just, I'm an alumnus of FMC. I worked a large period in Army Hospital. And now after retirement, I'm working in Apollo CBCC in Ahmedabad. So this is the outline of my talk. So actually, we will cover all this. And obviously, if any question answers, we'll take it at the end of the session. And let me start with the history. Nothing is complete without the history. And if you see on the left side of your slide, the first description was as early as 1271, okay, in the mythological stories. Then came the understanding of DVT, the physiopathology, which was nicely elucidated in the 1600s and up to 1800 by people like Weizmann, Hunter, and the great man Virchow, shown on your right side. Then came the discovery and developments of anticoagulants, started with the hirudin from the leech in the 1800s. By 1900s, we'd already discovered heparin and also the oral anticoagulants like warfarin. And the modern molecules, we're going to talk about it, whether it's the low molecular weight heparin or the newer oral anticoagulants. Now, this J. McLean is a student. He was a student in Johns Hopkins, Baltimore. And see what he did. In 1916, as a second-year student, they all do a little bit of research work. He was working with a physiologist called Henry Howell in Johns Hopkins. McLean extracted the dog liver and found that in vitro, it had anticoagulant properties. And Howell went on to name this as heparin because this was an extract from the liver. 2 decades later, in 1937, actually, the first crude form of heparin was actually in a saline solution and was injected and found to have no real toxic adverse events. So that was the first clinical exposition of heparin. Then if you see the dicamerol story, you see, if you see, it started as a rat poison, you see. In the 1920s, cattle farmers were losing cattle and sheep to a hemorrhagic disorder after eating spoiled batches of sweet clover, okay, which was contaminated with molds. Carl Paul Link was an American biochemist who discovered in 1945 warfarin and actually launched it in 1948 as a rodenticide. The rats who ate it bled to death. So they found it is a very effective rodenticide. A few physicians tried to play around with this in the Cornell Medical Center, but very soon they were condemned by the other physicians and it died a natural death. Till 15 years later, the president of the United States of America, President Eisenhower, was hospitalized in the Walter Reed Army Hospital, which is the earmarked hospital to treat the presidents of the US. And there he had a myocardial infarction. And they found that he had clots. And his doctors actually ended up giving him warfarin. And what benefited him helped to remove the stigma which other physicians attached with this. And warfarin was born. And this is the sweet clover which the cattle ate. And this is Carl Link. And the name warfarin is actually an acronym. It stands for WARF, which comes from the Wisconsin Alumni Research Foundation, and Aryan comes from coumarin. So that's the name, that's how warfarin was coined. Now coming to the normal physiology, as you can see, the calf muscles is what drives the vein upwards. And the calf muscles are called the peripheral heart, because without them, you will not get the pressures generated required to pump the blood upwards, especially in an upright posture. Also, the valves help. They break the vein into segments, and the small segments are easier to push. And the valves is a one-way traffic. So what happens is blood is pushed up in columns of segments. And the pressure is highest at the ankle, and it keeps decreasing upwards toward the heart. So the blood is driven upwards. So if there's something wrong with your peripheral heart, you're obese, you don't have muscles, you have fat-laden calf muscles, your peripheral heart won't work. There'll be stasis. You'll get varicose veins. And if the valves get destroyed due to whatever reason, your blood is not broken into segments and they will have stasis. And stasis, as you know, is a precursor to clots formation. So Virchow triad has stood the test of time. I showed you this great man's photo, and as a matter of fact, what he elucidated, hundreds of years ago still holds good. And that is from left to right, endothelial dysfunction, hypercoagulability, and stasis. And endothelial dysfunction can be due to various factors as shown, and so can hypercoagulability. Now in hypercoagulability, I want to tell you, the blood has some natural anticoagulants like protein S, protein C, antithrombin. It also has some procoagulants. All your factors from 1 to 13 are all procoagulants. Then you have a fibrinolytic system which inherently will remove clots which are not required. We have cuts and the blood stops bleeding because there's a clot. But that clot also does not have to be inside the body. Wherever there are clots inside, the fibrinolytic system dissolves it. So what happens is, if there's a defect in the fibrinolytic system, the clots are not dissolved, whether the clots are in the coronaries or the clots are elsewhere. So that will also promote clot formation and contributes to hypercoagulability. Now, of late, we know that the WBCs and broken plate, particles of white cells and platelets called microparticles also form foci on nidus for clot to form in whichever part of the microcirculation they are. So that also contributes. Then a large part is contributed by stasis. I will show you how we have now worked out for soldiers. Hypoxia is a very big part which causes stasis, because with hypoxia, you move less. Your effort tolerance is poor. So when you move less, your muscles work less, there is stasis. And if you have, your naturally occurring anticoagulants are not there, and your blood flow in the other parts are not good, your heart is not pumping as effectively, your ejection fraction is poor because of recurrent heart attack or cardiomyopathy, there will be stasis because there will be venous pressures will go up. whatever the veins are bringing, the heart is not able to empty. So that's a form of heart failure. So all these are clinical risk factors. Now below are something that we have learned of late. Indwelling catheters, venous catheters, long catheters, central catheters, all provoke clotting. Okay. Hereditary thrombophilia came with a bang, in the 70s, 80s, and 90s. Then they thought they had found the panacea for clotting. But today we know it's just 5 to 8%, which is contributed by hereditary thrombophilias. I'm not going to talk about it, but basically thrombophilia is a propensity or a tendency to clot, especially when you don't have, protein C, protein S, antithrombin, the naturally occurring anticoagulants. When they are deficient, you have a tendency to clot, but they only contribute less than 10% to the overall picture. Immobility is the most common acquired cause of thrombosis. Post-surgical, post-operative, post-ICU admissions, all these cause immobility. Now, this last part, please pay attention to this. Major and minor acquired risk factors can be transient or persistent. So the major transient, major means there's a risk, but it's transient. Surgery and trauma, obviously. Major persistent, cancer and antiphospholipid antibody syndrome. Cancer, especially if it's metastatic or it takes long to cure. Minor transient is immobilization, but I want to draw your attention to long distance travel. Flights which are more than 4 hours, like you have transatlantic flights, trans-Pacific flights, they can be 16 to 18 hours. And all these actually predispose people, especially who are obese, older age, have comorbidities, they are all then more prone to, so you'll find an advisory in all the airlines to this effect. Pregnancy is a physiological cause for hypercoagulability and estrogen therapy for whatever reason. Minor persistent is because of advancing age, obesity, and comorbidities. So this is a very important part I want you to know. Accordingly, we anticoagulate them. That dictates how long you will anticoagulate, which is so important, because anticoagulation is a double-edged sword. In one hand, helps to treat clotting, but other hand causes hemorrhage. This is the good old thing all of you have learned in MBBS. You have the intrinsic, which is the contact pathway, and you have the extrinsic as shown on the right side. Both converge to the common pathway and leads to a clot. And then when clot occurs, you have deep vein thrombosis, which is blood clotting. And commonest is in the legs. It can occur anywhere in the body. Pulmonary embolism, when this clot dislodges and travels up and blocks your pulmonary arteries or any other part of the body also. So thromboembolism can occur. So combined plus minus the two of them is referred to as VTE or called venous thromboembolism. Now they both require a few lectures to cover. So today we will restrict our talk mainly to deep vein thrombosis and blood clotting, and pulmonary embolism will be covered, and I think has been covered partly by the cardiology series. But obviously today we are talking about DVT. Now you see, this was not unknown. You see, in 1959, Lancet has a publication which says elderly hip fracture, 300 patients randomized to 150 oral anticoagulants using the older one called phenandione, and controls not getting it. And what did they find? They found that pulmonary embolism as a cause of death was only 8% when they took oral anticoagulants versus 26% in the control group. Very significant. So we knew this as early as this. We still haven't mastered it. We are still struggling. And that's why this talk is being given today. So that you have an awareness, whether you're a surgeon, whether you're a gynecologist, whether you're a physician, whatever super specialist you are, this is relevant for you. Now, when I was a student and later on in my MDs in the 80s and 90s, let me tell you, it was considered a local disorder and treated by the surgeons. And the main topic was dealt with in Love and Bailey, which is the main book on surgery. Okay, which is the main book on surgery. But DVT is now considered DVT is now considered a systemic disorder, and it has a multidisciplinary approach by a hematologist, a cardiologist, a critical care specialist, and a vascular surgeon, and we have DVT clinics. I'm giving a talk. So if you see here, the estimated incidence, this is very important. You see the ethnicity per 1,000, okay? In whites and blacks, it's 1 or more per 1,000. Hispanic and Asians, it's actually Asian less than 0.5. So they say the Asians clot less, and this incidence from the West. So it's a multi-ethnic data. Besides, this age is very, very important. Less than 15, only 0.5 or lesser. More than 80 years, it's 10 times more, 5 to 6 per 1,000. Males are more commonly affected, and so overall 1 to 2 per 1,000 is the incidence. Now, DVT does not spare a politician or a sportsman. All these famous personalities shown here had DVT, and some even had pulmonary embolism. From President Eisenhower to Serena Williams had pulmonary embolism. Steve Waugh, Flintoff, our good old Navjot Sidhu, Hillary Clinton, all of them had DVT, and some of these also had pulmonary embolism. So DVT spares nobody. Now, if you see this graph, Preeti, is my screen fully visible?
Yes, sir.
Okay, okay. So if you see this graph, see the light blue on top. In 2006 to 2050, the incidence is going up from less than 1 to, it's going to touch 2. And why is this occurring? For the following reasons. Age expectancy is going up, and I told you with age, there's more clotting. Malignancies with age increases. So older the age, more malignancies. I'm asked very often, itna malignancies kyun diagnose ho raha hai? The reason is we are growing, we live longer. So malignancies are more, which is more diagnosed, and you see more of malignancies. And malignancy is associated with cancer, we know that. Number 2, we treat aggressively today. And many of these so-called transplantations, chemotherapy require long catheters, central catheters, and drugs are very toxic. All these agents actually iatrogenically end up causing thrombosis. So we know thromboembolism is not only endogenous, it is exogenous. So it's a double-edged thing, you know, you treat a person for curing something, but you give him something else. And it can kill, VTE can kill. So obviously, it's a problem of the modern era today also. And unlike bleeding disorders, you know, when there's bleeding, there's alarm. People run to the hospital. People run to the doctor. VTE is a silent killer. Why I call it a silent killer? Because, you know, 2/3 of them are not symptomatic. I mean, they're not symptomatic. You may not report to a doctor. And if you don't report to a doctor, it can silently kill you. So like diabetes and hypertension, it can be a silent killer. So it's important for us to know and pick it up. Okay, so what are the complications that we dread in DVT? The acute ones are pulmonary embolism, venous gangrene. 1/3 of them will develop symptomatic pulmonary embolism with all the symptoms of palpitation, tachycardia, shortness of breath, chest pain, and they will come to a doctor. While 2/3 will have asymptomatic PE. This is the dangerous one. He can progress to symptomatic later. But you know, if the high-risk people are identified and monitored, you may be able to pick them up. The chronic complications are as bad as the acute. They may not kill, but they impact the quality of life very badly. And some of them actually even commit suicide because of this, because it's that bad. Recurrent venous thromboembolism, pulmonary arterial hypertension can make you a cripple, and you have post-phlebitic syndrome, which is terrible. I'll just show you. So post-phlebitic syndrome, or PPS, also called the post-thrombotic syndrome, remember 30% in 3 years and 50% in 5 years. Easy to remember. Fatal pulmonary embolism, 10% of all hospital deaths. By the way, there's a postmortem series from PGI published on this. And this is how DVT looks. can be red, angry, painful, and on the right is venous gangrene, which is a terrible situation. You can lose digits and you can lose a limb. And you must know and treat to prevent recurrence, which is the worst thing. So concentrate just on the upper part. So there are certain risk factors for recurrence. If you know this, you will monitor them. Prevent recurrence. So anything which is proximal to the popliteal vein, upwards of the popliteal vein is called proximal DVT. Distal to the popliteal vein is called distal DVT. And that does not usually cause thromboembolism and resolves by and large on its own. Proximal DVT can result in pulmonary embolism. So we pay full attention to this. It occurs more often in obese people, in older people, in males, and obviously people who have malignancies and people who have a lot of comorbidity like heart failure and other cardiovascular problems. So these are the people who are more prone to get recurrence of DVT. And we have various models which you can go through. But just to say there are 3 such models and we score them by just taking the D-dimer level, if it's a male, and the location is it distal or proximal. And then we say, okay, does he have a risk or not? And accordingly, we counsel the patient, okay? So coming to the post-thrombotic syndrome called PPS or post-thrombotic syndrome, PTS, I told you up to 50% in 5 years. It terribly reduces the quality of life, is costly to treat. And what are the risk factors? The risk factors are raised D-dimer after completion of the course of anticoagulants. More common in proximal, when there's extensive iliofemoral DVT. When there's recurrent DVT, you have more chance of a post-thrombotic syndrome. Obesity and older people because they have very poor calf muscles, so the peripheral heart doesn't work. And the people who have varicose veins, and heritable thrombophilia was more of a hype. It does not have such an impact. Now, early ambulation and continued physical activity will reduce the risk. Most often in the older time, they say, thrombosis ho gaya, bed rest. Please don't let him move. Embolism ho jayega. No, it's just the opposite. Ambulation will help to prevent everything. The pulmonary embolism and also the post-thrombotic syndrome. So that's why today, within 24 hours, in major surgeries, patients are ambulated to prevent this. See how bad this looks. A post-thrombotic syndrome, extremes are what you see on the right. He cannot wear a shoe, cannot wear socks, cannot go for any social gatherings, becomes a social outcast. And some of them have committed suicide. And when you do skin grafts, the skin grafts don't take. And what is sad is, this is preventable, ladies and gentlemen. So if this happens, we are to blame. So today this should never happen. Luckily, we see not more than 10 or 20% of what we used to see 10 or 15 years ago. And the early symptoms are shown on the right side, on your left top, hyperpigmentation, a venous ulcer comes, venous ectasia, skin induration, all these things come, that something is gone wrong. So you must get into action straight away. So prevention of venous thrombosis and DVT is any day better than cure. You can repeat this 10 times. And this is a public health slogan. So then how do you prevent thrombosis is the most important before you come to management. So how do you prevent? So this is a very important large study called the ENDOR study. Worldwide, large number of recruits, India also participated, global study. So if you see, over 68,000 people were recruited. And what did they see? They saw actually who are at risk for VTE. And if it was at risk, were they giving anticoagulation? If there was no contraindication to anticoagulation. This study was all about that. And what did they find? They found that only just about 50% actually got it. 48% never got the thromboprophylaxis. So he was a candidate for VTE or venous thromboembolism. So if you see the summary here, 68,000 screened, at risk was 35,000 got some anticoagulation. Sorry, out of the 35,000 who were supposed to get, who were at risk, only 17,000 actually received prophylaxis. You see, and the Indian subset, 11,000 were at risk, and only less than 20%, only 192 were getting anticoagulation. So we are very badly off. And the medical people did worse than the surgical people. And among the medical people, the oncologists did the worst. So they were my fraternity. It's a long way to go. Okay. So we started very early. This paper I published in the Indian Journal of Orthopedics, where we had nearly 1,000 patients. So if you see your right side, the prospective group had nearly 200 and the retrospective had 800 patients. The retrospective got only 10 to 14 days of anticoagulation. That means till they were ambulated and they were discharged, they were given anticoagulation. They were discharged without anticoagulation. While 200 patients here, or 197 to be exact, got anticoagulation for 4 weeks. We made sure we monitored them. And we had only one patient who got, that is 0.5% of venous thromboembolism. That also did not die. And 3.27% got in the retrospective group. And this p-value was significant. So extended thromboprophylaxis, today we have different protocols, but benefited to prevent VTE. That was the take-home message here. And if you see, it's no different in the ICU. So if you see this meta-analysis, more than 60% reduction in fatal PE and nearly 60% in the non-fatal PE. So overall, you're reducing not only the VTE, you're reducing fatalities, which is so important. So if you see now, there's a growing interest in venous thromboembolism, and COVID actually really gave a thrust to it because COVID had thrombosis. So we gave a few talks, and they're on the YouTube, you can see, on COVID and thrombosis, okay? Now, public interest and the healthcare fraternity interest grew. And so patient advocacy became a reality. So VTE is now known as the most preventable illness in hospitalized patients. And what is my target and your target? Is to have a concept of DVT-free hospitals. So we are doing some projects this. And we are actually involving public and private hospitals. And, we will certainly have NAMs associated in this to have DVT-free hospitals, okay? And in the US, most states have already adopted a thrombosis awareness month. So we're going to do that in India too. And Medicare abroad, and very soon it will be in India too. If a patient is admitted for a major surgery and has a thromboembolism in the first week, either dies or doesn't die, will they be compensated by insurance? The answer in the US is no. In India, still we are getting it, but it's called a never event, and you will not be reimbursed. So ladies and gentlemen, we have to wake up. This is a wake-up call. So this Kakkad, the second and third, Vijay Kakkad and Ajay Kakkad are from Bath's Hospital, London. They're vascular surgeons. Vijay Kakkad is an alumni from Maulana Azad. And as a matter of fact, he was a co-founder of low molecular weight heparin, ladies and gentlemen. I don't know how many of you knew it. So they came to India and they do a lot of research on thrombosis. They have an institute in Bangalore also. And that's called the Thrombosis Institute. Okay, they have one in London too. And they involved all of us and all these major specialties. And as a matter of fact, I headed the hematology group. Likewise, there was surgery, oncology, critical care, orthopedics, gynae. And what did we find? We put together the complete data available in 2006 and 7, Indian publications. And we found that we had a whole host of unanswered questions in the field of thromboprophylaxis. No carefully designed research protocols existed. And we said we must make them. So these suggestions were implemented specialty-wise, and we come a long way after that. Many specialties have already done it. Many are in the process, and some still have catch up to do. Now, ICMR has taken a very active, and I congratulate Dr. Balram Bhargav for his activities in this. They started the national hospital-based dynamic registry on venous thromboembolism called the iRegVed. All these hospitals are already dynamically giving their data to ICMR. And let me tell you, these numbers have increased and will carry on increasing. And I'm sure most hospitals will be on it in sooner than later. Okay, and that data is going to be a treasure of gold. We will know how to intervene. Okay, And NAMS is not to be left behind. Our president, Dr. S.K. Sareen, Dr. Kapil, and the complete team NAMS went ahead and identified unmet needs in the medical field, from multi-drug resistant tuberculosis to venous thromboembolism to organ transplantation, and published some sort of advisories which can be actually co-opted as guidelines by the government of India. But this has been sent as documents to the Ministry of Health. I was lucky and fortunate to be appointed as the chairman of the VTE task force. The top colleges of the country participated. And within 8 weeks, we formulated a document which actually was released by NAMS, actually, and by the erstwhile Chief Justice of India. And this document is a comprehensive document and will complement the registry with ICMR has published. And we have put together all existing Indian data in this particular document. Now, what is the at risk for VT, for venous thromboembolism? I would just like to say the high death rate from pulmonary embolism exceeds myocardial infarction. And the high risk of undiagnosed pulmonary embolism causes sudden cardiac death, and which is the need of the hour to emphasize our preventive efforts. Failure to institute prophylaxis is a much bigger problem with medical patients than surgical, which I told you. And I also told you that 80% of this belonged to medical patients, and the bulk of medical patients were medical oncology patients. So we obviously have to sensitize our fraternities to actually overcome these blocks. So how do you approach a case of suspected VTE? First you must know who are at risk, and that's called the pre-test probability, PTP. And this gentleman, Dr. Wells, is from Canada. What he published in New England Journal of Medicine holds good even now. There are many other scores, but his is validated and has stood the test of time. There are 9 variables as given here, all of them predisposed to thrombosis. And if you have alternate diagnosis like cellulitis or a Baker's cyst which is ruptured, which can mimic a thrombosis or a DVT, you get -2. All they get +1. For lower limb DVT, anything more than a score more than or equal to 3 has got a chance of 50% prevalence of VTE. And 0 score has got less than 10% chance. Upper limb DVT a little bit more tricky. We have something called the constant score for the PTP or the pretest probability. And here, is he on a central catheter? Is he got a pacemaker? Localized pain and edema, and an alternate diagnosis like cellulitis, trauma will be -1. So anything scored 2 or 3, he has 40 to 50% prevalence of a VTE. So this is something we have to train our nurses to score. So all patients in the medical ICU must have a scoring system. So if he's got this, he's got DVT. Likewise, we have for pulmonary embolism also. So you can see if I combine the DVT and the pulmonary embolism scores, I can prevent this by just intervening with thromboprophylaxis. So how do I end up diagnosing this? So it's a very simple rule, and this is for VTE, that is DVT and pulmonary embolism. So if you suspect it by the PTP, you have the unlikely candidates with 0 scores and the likely candidates with 3 or more scores, or 2 or 3 or more scores. So if it's likely, straight away go for ultrasonography. And if you suspect pulmonary embolism, you go straight for pulmonary angio. If it's unlikely, but he's a candidate, otherwise, he's obese, he's admitted in the ICU, do a D-dimer. If the D-dimer is positive, still do ultrasonography. And if it's a pulmonary embolism candidate, you may still have to do an imaging for pulmonary embolism. And if this imaging is negative, you have excluded DVT or pulmonary embolism. If it's positive, you've diagnosed it. And if the D dimer is negative, you again excluded DVT. There's only one additional thing here on the right in yellow I've highlighted. The D dimer, when we talk, this age-adjusted D dimer threshold is calculated as the patient's age multiplied by 10. So if he's 70 years old, it'll be 700 nanogram per ml. The labs give a cutoff 500, but his cutoff will be 700 if he's 70 years old. This is a new thinking, and this is now being applied. But the labs still give a cutoff of, suppose it's suppose it's 500 nanograms. It'll be for all age groups. So age adjusted is now a new thing which I think we should know. So if you have a high index of clinical suspicion, AI, artificial intelligence, your scans, everything is very good. But I think we are far from replacing an astute clinician. So as a clinician, if you suspect that there is thrombosis, but everything is negative, I will not leave that patient. I will still chase it. So I will repeat a compression ultrasonography after 1 week, or repeat a D dimer after 1 week. I will not lose him to follow up, because many of these people where everything was negative come back dead after 2 weeks because these tests were negative. But there'll be one in 1,000 or 1 in 2,000. But that's how you pick it up. So clinical suspicion is extremely important. So what are the sensitivity, specificity of the various diagnostic tests? I would say in 20 years ago, contrast venography was still being done, and it was the golden yardstick. But today it's the imaging, ultrasonography, whether it's the B mode, whether it's Doppler, whether it's duplex, all of them have 99 to 100% sensitivity and equally good specificity. This is mainly for symptomatic when he's come to you with complaints. Suppose you're doing a prophylactic screening where he does not have symptomatic DVT, the specificity will fall. And for distal, less than when it's more distal to the popliteal vein, that in knee and below, called the distal DVT, it's the specificity of imaging falls to 75% from nearly 100, when he's symptomatic or proximal. So this is important. Distal DVT may be difficult to diagnose. Thankfully, they are less dangerous. MRI also contributes. D dimer we do very frequently, but what's important is very sensitive, but poor specificity. So what is the significance of D dimer? So D dimer, if you see, there are various kits. And if you see the cutoff 500 nanogram per ml, or some, point of care will give you, so it's lab based and the insert will give you. Sensitivity, excellent, but you see the specificity is half of it. So you still, may have a lot of, false positives, but your sensitivity is right up there. Okay. So it's got a negative predictive value. That's what's important part. Okay. It's got a high negative predictive value, NPV. Okay. Now these are point of care instruments. Now it's there. ELISA tests are more sensitive than the latex, and the sensitivity, like I told you, is better for proximal than distal. And you can't extrapolate one test kit with the other. Okay, same thing here. Specificity is 50% of the sensitivity. What are the major diagnostic advances? One is the age-adjusted D dimer threshold, which I just told you, multiplied by 10, and that will be the cutoff. And also seeing the pretest probabilities, like I told you. Now, the second point is very, very important. The critical care specialists. In the US, there's something called the emergency physician, which is nothing but the critical care physicians. They are all trained in compression ultrasonography. So they are the first one to do the ultrasonography, and it's been validated. Their performance results is as good as that of a ultrasonologist from the radiology. So what's the message here? The message here is that sometimes the radiology department does not work in the night in most of the hospitals, except for emergencies. So most of them don't get their ultrasonography done after working hours. But if it comes to the ER, you have the emergency physician or the critical care physician. They are trained with it, and they are giving results as good as the radiologist. So that's one advancement which has occurred. Okay. And very obese people, ladies who are pregnant, who cannot be put through any radiation, especially I can't do a CT. So MRI comes into play. Very obese people, your iliac veins are not picked up very well. Your pelvic veins are not very well picked up by an ultrasound. Postpartum people, obese ladies, or any obese people, your pelvic, which is a very common place for thrombosis, you will not pick it up by your ultrasound, okay? MRI helps you. And then you have the VQ single photon, which has come of age. This is not available yet. It's on trial phase, but it's actually one of the advancements in picking up your pulmonary embolism. I've already told you this, so I'm not repeating it. So cancer associated is very, very huge. And you can see that it is 20% of all venous thromboembolism occurs in cancer as a second leading cause of mortality. And our Indian data has shown from 10 to 15% of thromboembolism is because of cancer. In cancer, you'll see the commonest cancer on the right side you see is pancreatic cancers, followed by lung and stomach and colorectal cancers, okay? And if you see post-op, you'll see the esophageal resection and the cystectomies, radical operations are more prone to thromboembolism, and about 3.5 to 5% can end up. On the right side, you see that the black one is people who got no VTE, survived longer than the white one who got VTE, and p-value is significant. So thromboprophylaxis, if you give, you can get the black curve and no VTE, and the obviously survival is much more, 80%, compared to the ones who got VTE, it's less than 60%. Occult, VT, cancer in VT. That means I get an unprovoked VT. It's very important. That is the catch here. Unprovoked DVT, especially proximal, popliteal, femoral, iliac vein. And that can be the first manifestation of undiagnosed cancer. So published data shows that nearly 5% of them will detect to have cancer within 1 year of follow-up. So clinicians should have a very low threshold to pick up cancer, especially in people who are older, who could have prostatic CA, who have altered bowel habits, who could have colorectal CA, who have ladies who have cervical, who have postmenopausal bleeding, spotting after menopause, who have breast lumps. All these people are prone to get DVT, but definitely you must follow them up. So in the past, we were screening all of them who had unprovoked DVT for cancer. Then we found it is not cost effective. So it's best to follow them up clinically and actually only do a good physical examination with a basic blood biochemistry and a basic imaging, and counsel the patient for follow-up, and then do targeted screening every year if required, if there are new findings. But we don't screen everybody because it's not cost effective. So what are the risk factors in our cancer itself? It's patient related because of various comorbidities. Tumor related, something like pancreas, I showed you, a much higher propensity. High histological grades of tumor will have more chance of DVT. Treatment related, some of the chemotherapies we use, some of the anti-angiogenesis like thalidomide, lenalidomide, all cause thrombosis. Biomarkers, besides many others, D-dimer I've already told you. Okay, then you have one of the scoring systems, the scoring systems helps you say, whom should I keep back, observe, and keep him under screening, maybe monthly for 6 months or longer, who have high scores. So Khurana is Indian. So he said, with cancer people, please put these scores. And if the scores is more than 3, keep him under your follow-up closely. But if he's 0, call him once in 3 months or once in 4 months. So it's basically for follow-up. So these are all available on the net, but you should know how to use them. Okay. This is the same thing. I am not going to repeat this. And in them, now we know these scores when we use, we use now newer oral anticoagulants. Okay. And the low molecular heparin is still available with us, but everybody wants, can we use the newer anticoagulants? So they are given on top. Now, amongst them, what did we find when you use? All of them have been used. That is edoxaban, dalteparin, rivaroxaban, epixaban, and all of them have been compared with the conventional ones like low molecular weight heparin or dalteparin. And what did we find? See the bottom. lower VTE recurrence with the newer oral anticoagulants compared to the LMWH. But there was a higher bleeding risk among GI and GU cancer, genitourinary cancers. So today we know that we scan them. If there's no bleeding, only we use. And some of the drugs don't cause it, so we know what to use. So even this threat has been dealt with. This we all use, central venous catheters and catheter-related thrombosis, okay? And this leads to the upper limb thrombosis. And upper limb thrombosis, nearly a third of them can have pulmonary embolism because so close to the heart. And the classical features of DVT are lacking. And your ultrasonography will not pick up the diagnosis. You need a venography, you need a CT or an MR angio to pick it up. So it's more difficult to diagnose. So you must know when to suspect it. Okay. So recent studies have shown that the older one was only 2 to 4%, but today it's more than 10% of all newly diagnosed DVTs are in the upper limb, which is alarming, you see. And central venous catheters, out of this 10%, 50 to 90% is due to central venous catheters. So I would say nearly all of them are due to central venous catheters, you see. It's so important. And all occurs in the first 3 months of inserting a central venous catheter. Most of us in our malignancies keep them for 1 to 3 months. So that's when it occurs, okay? And it's a strong independent risk factors for thrombosis. And this is how it occurs. You see, this is the catheter and this is the vein outside. This is a fibrin sheath first occurs, then an intraluminal clot occurs, and it can have clots with the catheter and the vein wall, and then the venous thrombosis involving the whole vein. This is diagrammatically shown here. So this is how a venous thrombosis occurs. Okay, and this is just the various types of tunnel catheters, non-tunnel catheters, which all of you may be Portacath, Hickman catheters, and EPIC, which is peripherally inserted central catheters, very commonly used. But you must know that all of them can cause thrombosis. Okay. Now the risk for thrombosis with the devices. You see on the left, multiple insertion attempts. So it's important that if a resident attempts 4 times, 5 times, that person will get more chances of a thrombosis. While you go through clean first time, the chances are lesser. Femoral vein will have much more chance of a thrombosis than a subclavian because the site and the trauma. Large catheters will have more chance of thrombosis. And amongst the catheters, a PIC or a peripherally inserted has more chances than a chemoport. Okay? And an improperly inserted catheter position, it should come to the junction of the right atrium and the superior vena cava or the atriocaval junction. If it's not there, if it's lying in the superior vena cava or is lying in the subclavian, you are more chances of getting actually thrombosis because whatever you're injecting through there is not diluted well enough because of the flow rates. Larger catheters with more lumens are more prone to thrombosis. The material, the cheaper ones are polyvinyl hydrochloride, the PVCs. But today the costlier ones are silicone or polyurethane, much lesser than this, much lesser, okay? So these are the risk factors which you should know, okay? And now, is there any role for thromboprophylaxis to give, anticoagulants? The answer is no. The answer is no, okay? So the answer by all various agencies is no. So how do you treat catheter-related thrombosis? Is firstly, once the thrombosis is established, I will anticoagulate. And with what? You can use any of these agents. Heparin, oral anticoagulants, the newer ones. And how long? Usually we give for up to 3 months, okay? And we don't remove the catheter. You remove the catheter if there is associated infection or it's blocked or you don't any longer need it. Otherwise, it will also recanalize, but leave it there. Don't fiddle around with it, but anticoagulating. What are the goals of treatment in venous thromboembolism? The first thing is he should not be a bleeder, which is what we all miss. Does he have a peptic ulcer? Does he have recent surgery? Is she having menorrhagia? So all these history of bleeding you should know, and no contraindication to anticoagulation should be there. And then once you've got the thrombus, prevent the extension. And then preventing extension, you prevent embolization. relieve the symptoms, and obviously reverse the occlusion. Long-term goals is to prevent recurrence, prevent, I told you, PTS and pulmonary hypertension. Okay, and the possible contraindications for bleeding, thrombocytopenia and bleeding diathesis are the commonest. Major trauma, uncontrolled hypertension, recent surgery, anything in the neural axis from the brain to the spinal cord, avoid it. Because if he bleeds into that tumor, you may lose the patient. Okay, and then there are some bleeding, scores, and they're all very simple. The presence of comorbidities, older age, and using other drugs. There are points given, and anything more than 2 points is usually point towards a bleeding risk. So it's good to put the nurses, residents, and the team that who are more at risk for bleeding. So then why have we now gone to the newer anticoagulants? Warfarin was the sole anticoagulant for 6 decades. Narrow therapeutic index, delayed onset of action, regular lab monitoring, lot of drug interactions. The novel anticoagulants have changed all this. It was called novel oral anticoagulant because it was novel. It was discovered in 2010, introduced as dabigatran for heart problems. In the next 5 years, 3 more were discovered, were put into the market. And once 3 more came, it's no more novel. So the word novel was removed. It actually also was called as non-vitamin K oral anticoagulants, NOACs. But then when the world voted, the International Society for Thrombosis found that they all voted for direct oral anticoagulants or DOACs. But even now, DOAC and NOAC are used interchangeably. So when you start a DOAC, in the beginning it was prohibitive cost, we couldn't use it. But remember, the other thing that you look at is creat values. GFR should be more than 30. The dosing and the drug interactions you must know. And dabigatran, rivaroxaban, apixaban, edoxaban now are all in the market. The first 3 are available in India, and the generics are available also. And you can use it for all the indications on the left: atrial fibrillation, venous thromboembolism, and for thromboprophylaxis in surgery, especially orthopedics. Except edoxaban was not cleared for surgical prophylaxis, but the rest are all, and we are using it. So the DOACs, if you see, just to tell you the basic things, that is the half-lives is anywhere between 10 to 12 hours in all of them. But only thing is renal excretion, dabigatran is mainly kidney excreted. All the rest is only 1/3. But kidney is mainly for dabigatran. And dosing, dabigatran and dabigatran and apixaban are BD dosing, and the other 2 are OD dosing. Okay. And I will tell you about the bridge part, that is a little later. And the cytochrome oxidase system and the PGP, all the drugs which are metabolized through these liver mechanisms will interfere. So some will induce and some will inhibit. The inducers are chemotherapies which are shown, but steroids is important. So the inducers will reduce the levels of the NOAC or DOAC. So the effect will be lesser. While the inhibitors will increase the levels, and they are all the chemotherapies, and including imatinib, and your paracetamol. So all of them may increase the levels and cause bleeding. So that's important for you to know. The common drugs you must know. So you must have this chart in your pocket or in your mobile. This is how you interconnect. Suppose somebody was low molecular weight heparin, I want to put him on a DOAC. Extreme right top, you see LMWH he's taking, I want to convert him to DOAC. What do? I stop the LMWH and start the DOAC at the next dose itself. A patient was taking DOAC. I want to convert him into a low molecular weight heparin. So what do? I stop the DOAC and the next dose can be the LMWH, no problem. Okay. Only thing is whenever DOACs and low molecular weight heparin, always keep checking the creat should not be high. So when I want to start a oral anticoagulant like vitamin K, warfarin, and the patient is on DOAC, and I want to start warfarin, what do? I will only start when the INR is 2 or below. So I should keep doing the INR till the INR is 2 or below. I will not introduce the DOAC, because if he's got high INR 3 or more, or even 2.5 or more, I should be careful. The DOAC, when you really restart, you may cause bleeding. So wait for the INR to come down. Okay. So these charts are available, but basically it's very easy to change. That's the point that I'm making. Okay. It's affordable. See the cost on the right side. The generics are now, even the original molecules are affordable because of the cap put by the government of India on the costing. Okay, these are the two drugs. All anticoagulants must have a reversible. Like, we give protamine, we give FFP for heparin. Like that, for DOACs, we don't have much, but for dabigatran, we have a monoclonal antibody, and we have Edixanet for the other ones, especially rivaroxaban and edoxaban, but it is prohibitively costly. You can source it, but it's very costly. Okay, the duration, when you start it, the dosing is on the left side. I told you BD dosing for apixaban and dabigatran and rivaroxaban to start off with. There's a loading dose over a period of 1 to 3 weeks. Then it comes to nearly half the dose. When you want to give it for 6 months, you can further go down. Apixaban, start with 10 BD, 20 a day for a week, and then you come to 5 BD, and this can carry on for a period of 3 to 6 months. But when I want to give lifelong, I'll come to 2.5 BD. So dosing is individualized depending on the conditions. Okay. Now what happens that he is continuing to get clotting despite anticoagulation. There are only few reasons. Either the patient not taking the medicines, or he's got a cancer which is active, or he's got an APLA syndrome, or he's got a myeloproliferative hematological disorder. But heparin-induced thrombocytopenia, HIT, can kill. So this is something I'm going to discuss. Okay. So here, I just want to say two things. We used to use a lot of compression stockings and say that the post-thrombotic syndrome will be prevented. Today we know it is not prevented. So a graduated compression stocking is used, but used on a clinician's recommendation, not as a prophylactic measure to prevent PTS. No. Okay. In cancer, we continue with anticoagulation till we stop the therapy. Okay. And then for distal DVT, today you can monitor. You may not even give him the anticoagulation. Okay. This I'm skipping. A few words on high altitude and thrombosis. Everybody must know what our soldiers are doing for us. And that's why I'm able to give this talk and you're able to listen, because he's guarding our borders and letting us be. Okay. And despite all screening that we have done at sea level, certain number will still get thrombosis when he goes to the Sichuan Glacier or to anything about 10,000 feet. And this thrombosis at unusual sites in the cerebral veins, in the portal veins, and the data is sparse and the subjects are young, and that's what is scary. And now with a lot of sports occurring, you have, and the wars being fought in the glacier. So it's a reality. The Lhasa train is between 9 and 12,000. So when people travel, many of them get high mountain sickness. Okay. And so I got interested very early in life. I started my career as a 2-star lieutenant. And that's when I was posted in the Chinese border in Tibet, in Lahaul Spiti. And I found the first case of DVT. And the surgeon treated and sent the patient back. And within 4 weeks, he was back with me. And I found that within a month, the patient again got thrombosis. I couldn't understand what I was treating. But from those days till today, I'm still researching thrombosis, ladies and gentlemen. And I haven't left high altitude thrombosis, okay? And I will tell you how we have done it. This is what our soldiers face. This is how gloomy it looks. When the weather packs up, only choppers is the answer. The roads are blocked, okay? And only the choppers can get your food, your mail, and take you back to a hospital if you're sick. Okay, so what are the existing data? It's mostly from the army. It's mostly published by us and by our seniors in very good journals. Okay, and we have contributed, our team has contributed the last 2 decades handsomely to this field. And we have, from portal vein to cerebral vein, we have actually published, and I'll just show you 3 quick cases. This soldier doesn't smoke, doesn't drink, was posted at 24,000 feet on the glacier, and he felt sick. His sensorium got altered, his toes got discolored. He could not be evacuated for 11 days because there was a blizzard. After 11 days, when he came to us, he had gangrene in 3 limbs. We had to amputate 3 limbs. And now he's got artificial limbs in all the 3. And here all organs were, kidney, liver, portal vein, brain were all thrombosed. We treated him for 3-4 months. We thought we will lose him, but he is now good, ladies and gentlemen. He is posted in Pune, and I have the permission to show these pictures from Major Rajesh. He is a success story. He got artificial limbs, robotic limbs. Okay, this soldier was posted on the Chinese border, and he came with a headache after 1 month. I struggled with him. I was in Calcutta, and what did we find? We found that he had cerebral sinus thrombosis with deep vein thrombosis. This was how the MR angio looked. And after anticoagulation of 6 months, it recanalized. He lived to tell his tale. What did we find? We found that this gentleman had actually a protein S deficiency, which was hereditary. His family had it. His brother died of a myocardial infarction at 40 years. This is the first case report in the world of this deficiency. Okay. Now we said, then we must, pay due respects to our young soldiers. So we designed this epidemiology of thrombotic disorders, and it took us 6 years to complete it at extreme high altitude. We completed it in 16-17, and we published this in Lancet Global Health. Okay, there were a large number of people who contributed to it, and we found some significant findings that why are they clotting? Why are they prothrombotic? And what did we find? We had a suppressed naturally occurring anticoagulants. We had dampened fibrinolysis. I told you, those clots are to be lysed. So when you go to high altitude, everybody forms clots. The guys who don't manifest thrombosis have a good fibrinolytic system, who don't clot. And that's because the endothelial activation occurs because of hypoxia. And this endothelial activation causes platelet activation because of the inflammatory markers. And that itself causes thrombosis. This is the most pronounced after 15,000 feet. And we showed it beautifully. If you go, it's a free download. All the supplements you must read to understand this. But it is a longitudinal study done over a few years. It's not a cross-sectional study. This is the only study of its kind in the world, by the way. So this is what we still found. After all that we did, 15 healthy subject got thrombosis who had to be flown out, 12 venous and 3 arterial. Okay, and these are the findings which I would ask you all to read. Okay, this was very well received globally, and we had a very good editorial which said this is the first finding to explain the thrombosis at high altitude. Okay, and I want to salute all our soldiers by to say to all of us, our flag does not fly because the wind moves it. It flies with the last breath of each soldier who died protecting it. Anonymous. These are the soldiers who have just come down from the glacier, and this is how we used to collect the samples. We were there every 3 months in the glacier. This is the highest hospital in the world. It's called the ADS base camp beyond Tangsei. Okay, and this is where we used to conduct all our research. What is HIT? Heparin-induced thrombocytopenia. Very important, 5 to 10%. Just remember that it is a very bad situation. There's a thrombin storm. Antibodies against heparin coupled with a platelet factor 4 actually activates the platelets. Okay, and remember the 4 T's. Thrombocytopenia, within timing 5 to 10 days of heparin, thrombosis occurring with thrombocytopenia, the 4 T's, suspect HIT. Okay, and this thing is so important. Unless you have a high index of clinical suspicion, you will miss it, ladies and gentlemen. And people end up giving more heparin, and you will kill the patient. So you must suspect it, and the lab tests will help you to actually pick it up. It's available in all the labs, and the immunoassay will say that it's positive, that most probably you have HIT. And if you have HIT, you have to stop heparin pronto. And after stopping heparin, you'll also may find some people skin necrosis like this. If you're an ICU patient on heparin, you find these black spots, and the patient is worsening while on heparin. Platelet count from 150,000 has become 90,000. Please suspect HIT. Please suspect HIT, especially the patient is older. Okay, and this occurs more in females. And these are the the 4 T's, how they occur. But very rarely with thrombocytopenia will he bleed. So there's the other odd things. When thrombocytopenia occurs, people bleed. But here it's usually around 50,000 or around that, but they don't bleed. And the drugs we use for this are non-heparin based. So these are the ones which we started with: agartroban, bivalirudin, danaporoids. But this is what we use now. Fondaparinux I've used a lot. Apixaban and dabigatran, rivaroxaban are all available, and this is what we use now. Okay. Now COVID, nobody can escape COVID. COVID affects all the vessels. We didn't understand. We are giving heparin to everybody, but we didn't understand COVID. But let me just throw some light. It can come with any type of embolism or any type of thrombosis, both venous and arterial, more venous than arterial. Okay. So, and most important is, we talk to our American colleagues, all the people on dialysis, because many of the patients of COVID were on dialysis, their renal circuits were blocked because of thrombocytopenia or whatever. They couldn't give heparin, but they were all clotted, the renal circuits. And the lines which they put, long lines, got thrombosed. So this is something is happening. So we did actually a very long meeting with a large number of people in the US to show that they actually are thrombosing. So what did we actually find? That those thrombosis can be dealt with by giving the right amount of anticoagulation. If he's got no bleeding risk, give LMWH or give one of the DOACs, you are okay. But what we found is when the vaccine came up, all these 9 vaccines or more now are approved by the WHO, and there are many trials going on in India. Okay, 2 of these vaccines are adenovirus vector-based vaccines. We used the Covishield, and one was Janssen by Johnson & Johnson. Okay, and we found that these 2 caused a vaccine-induced thrombocytopenia and thrombosis, VTE. And this was alarming because it occurred in the following people. Okay, it occurred more in females. It occurred within the first month of the vaccine, as early as 5 days. And they had documented thrombosis or severe persistent headache. And thrombocytopenia was always an accompaniment. And the D-dimer was usually raised to more than 8 times the upper limit of normal. And they were positive for antiplatelet for heparin IgG ELISA antibodies. Okay, and this they found was actually, like the HIT molecule, we had like the heparin antibodies. So that confused the issue further. So definite vaccine-induced thrombotic thrombocytopenia, first publication NEJM, definite VTE, if meets all the anticoagulation. Treatment, IVIG first, along with anticoagulation. And unlikely, if only the platelet count is low, but there's no thrombosis, D-dimer is not very raised, then you may follow up. But remember, there is a very close mimicker without thrombosis, but raised D-dimer, severe headache. But everything else is there, but no thrombosis. So 5 criteria not met, but 4 met. Don't leave him. He is a candidate with most probably he or she has VTE. So repeat your imaging, repeat your clinical examination. You will end up finding thrombosis. We treat them just like thrombosis and VTE. If he continues to have persistent headache, we give both these drugs. Okay, this is the difference in HIT and VTE. They can mimic each other, but suffice it to say that HIT will have obviously a history of heparin therapy, while this VTE has a history of vaccine, and that's the biggest difference, and they can otherwise present the same way. Okay, and I want to come straight to the treatment. I've told you IVIG high dose, 1 to 2 grams over 2 days, and thrombocytopenia is not a contraindication here to giving anticoagulation. So patient may have 70,000 platelets, please give anticoagulation. Only if it comes below 40,000, hold. Okay, so anticoagulation will be given along with IVIG. Okay, and then you can put him on other anticoagulants. Okay, and then I would say it is usually a first dose problem. In the subsequent booster doses, it was not found. So it's a first dose problem, and it's found after the adenovirus vaccines, very rarely after others. And when you had a Covishield and they got thrombosis, the second should be an mRNA vaccine, not the same vaccine. Okay, And then we come to the last few slides. Surgeon General in the US had said that no thrombosis DVT-free hospitals in 2008. And they said that if you have these, you must implement these 6 measures. You must have data, you must do thromboprophylaxis, and if you get thrombosis, despite having given you a warning, you will not be reimbursed. That means thromboprophylaxis has to be given, unless it's contraindicated, okay? So we must have awareness among the public, and we must know that all surgeons, all physicians, and the patients who are affected must know about thrombosis, okay? So the conclusion is you need extensive education of the healthcare providers and the public at large, and that's what NAMS is trying, that's what the ICMR is trying, that's what the government of India is trying. So all of us must join hands and have DVT-free hospitals. And for that, we must have data, and that's what the ICMR is doing. And we must know about the environment, high altitude, long travel, they're all preventable. So the health economics comes into play. What is preventable, obviously, is money saved, okay? And we have better anticoagulants now. So every hospital must have a strategy, and you have grade 1A evidence for pharmacological prophylaxis and perioperative prophylaxis. So evaluate each patient using the tools I told you. So ladies and gentlemen, prevention, prevention, prevention is the cure. Not better than cure, is the cure. Okay? With that, I would say Jai Hind. I have finished my talk, and I think we can come to the question answer session now. And I would stop sharing my screen. And we are on now for any question answer sessions. In the chat box, do I see any questions? Preeti?
So not yet, sir.
There are no questions.
Um,
So
There
if there, yeah, Preeti.
requesting all the participants to pose their questions in the chat box, or you can raise your hands.
Yeah. So till the questions come, let me address some things. Let me say something which we want of time I didn't say. Is it? So I'm very often asked, why is it so difficult to actually implement these strategies? The reason is doctors keep it within themselves. True doctors, they don't involve their nursing team. They don't involve their residents fully. They don't involve the medical officers. All the pre-test probability scoring is done by the paramedics, the nursing team, the technicians, and then your first responders with you, your residents. So you have to take classes and dynamically audit it. We are not doing that. I can't be seeing it 3 times a day, the same patient. The doctors and the senior consultants will not be able to do it. So that part, the team play comes into play, and I think that is lacking. And that may be want of manpower or because of other reasons. I think we must ensure that we train them and make dynamically, or it's not a one-day job. A patient is admitted in the ICU for 7 days. I can't score him only at entry and admission. I have to score him every day. The risk may come on day 3, or it may come on day 5. So the pre-test probability may be 0 on day 1, and I'm not giving him anticoagulation. Fine. But on day 3, the PTP or the pre-test probability may be 3. So I will anticoagulate him. So that the answer is dynamic assessment of the patient during the ICU management, and post-op patients, you should have done the pre-op assessment. Here is a patient who's come for an emergency road traffic accident. The patient is an old myocardial infarction. The patient is an old congestive heart failure, on anti-failure therapy, on cardiovascular therapy. But he's had a road traffic accident and a fractured neck femur. So the patients are going for a fixation of the neck femur. And if the neck femur is being fixed, he is a very high risk for thrombosis. So straight away in the pre-op itself, you said you have to tell the orthopedician, I am going to anticoagulate him minus 24 hours and within 12 hours of operation, I'm going to give it. Some surgeons may say even start earlier. So you have to be in conjunction. It's a multi-specialty approach to save those patients. It's not one doctor will do it all. I told you the DVT clinics, hematologist, orthopedician, general surgeon, critical care specialist, and the complete paramedical team. Okay, good. Congratulations. One question has come in. Among patients, nobody's put the name is who's
actually it is me.
Oh, very good, Preeti. Well done. Among patients who are injection drug users, should we use VTE? Yeah, good question. You know the so-called mainliners, you're calling them, no? The mainliners?
So we call them as people who inject drugs, PWI.
These are, in other words, the people who are addicted to drugs and who are mainliners.
Yes, sir.
Who repeatedly will take drugs.
Yes, sir.
My problem with them, yes, they are more prone to thrombosis. For the following reasons. One, they are very less motivated to seek medical advice. They will never come to you. Number two, they all cross-use needles. Their hygiene is very poor, so they get infections. Number three, they are not trained to give themselves injections, so they use the main antecubital foci, the easiest, that's where they inject. So they cause a lot of endothelial injury, sometimes multiple injections. So they are candidates for thrombosis there. And they are sick people because their nutrition is poor. And they usually have other diseases like they are more prone to HIV, they are more prone to viral disorders. So they are definitely at multiple risk factors. So they are. And unfortunately, we're very difficult to get them to the health clinic. So preventive strategies, when you do the other assessments, you should be trained to look for this also.
So there are I mean, we have an acid drug dependence treatment center and we see a lot of patients with injection drug users. And I had also worked under National AIDS Control Organization where under harm reduction programs, they give clean needles and syringes and they give some advice. But we provide some oral medicines to prevent the injection part. But we have never given any anticoagulant because
no data. You know, to give anticoagulant, you have to have hard evidence. The level of evidence has to be there. So unless you do a trial to prove that giving is more beneficial than not giving, even if he's prone, like I told you, you know, inherent thrombophilia, a chap who's flying 16 hours, they're all prone. But do we anticoagulate them? No, because the data is not. So cost effectiveness is a very, very important thing. So data is sparse. So you should now do a trial, Dr. Preeti. I'll help you design one.
Thank you, sir.
Next question is, should we monitor the patients who are on treatment with thrombogenic drugs like ESA and other regulated dimer? This are Dr. Manthan is a senior resident, and I would say yes. The trials, you have published data on this. That is why all patients on erythropoietic stimulating agents like erythropoietin, darbepoetin, all of them, when we use them in multiple myeloma or other disorders, the data is there that unless contraindicated, we use either low molecular weight heparin or we use 75 milligrams of aspirin. Because we do D-dimer, and if it's symptomatic, we even do ultrasound. So the next question from Dr. Shruti, in a suspected case of VTE, can graduated pressure stockings pose a risk of mobilization? This is a practical question. No, it doesn't. But the most important thing is ill-fitting stocking. So very often you have small, medium, large. And you know, you try to fit a medium on an obese person. So what happens, it becomes like a tourniquet. It's so tight and it's below the knee, the upper part of the graduated compression stocking, the GCS, curls down. And once it curls down below the knee, it acts like a tourniquet. It worsens the stasis. There's venous stasis because you know it won't allow good venous drainage. So it becomes a facilitator of thrombosis. So we don't use GCS nowadays. We say ambulate them. So, but if there's too much of swelling and pain, a correct fitting where the heel is shown, there's a heel pad, and it should be for a popliteal femoral, it should be only up to the inguinal ligament. And or if it's up to the only popliteal, then we should have only up to the knees. So we shouldn't overdo it. And it should be a correct fitting GCS if you want to. For the first few days, when you go to sleep, take it off. When you're walking around, wear it. But otherwise, no long-term role at all. And it does not cause pulmonary embolism. Yeah. So that was the second question. So the other thing, let me tell you all, you have a relative who's flying to Chicago or to New York on a 16 to 17-hour flight, non-stop, economy class. Okay, it's your grandparent, 75 years old, and the patient is obese and had old history of MI 5 years ago, now absolutely all right. Echo okay, and the cardiologist says you're fine to travel. What will your advice be for such a patient? So there is, travel advices by many airlines. There are surveys done, but obviously very difficult to do a trial, very difficult to do a trial. But there are data published. So whenever there's a high-risk patient and there is no bleeding risk, there be no peptic ulcer and no hemorrhoids, no recent surgery, and not on any other bleeders like, on NSAIDs. Very often people for arthritis and things like that are on diclofenac, on combiflam. So all those also cause bleeding, okay? So here you have to be very careful to advise anything. But the others, I would say two things. Firstly, I would say have water continuously. Have water continuously and keep hydrating yourself. It helps in two ways. Firstly, when you drink too much of water, you will want to go to the toilet. So when you go to the toilet, you have to walk. So you ambulate. So your circulation occurs. That's the first thing. And the other thing is alcohol. A lot of people who are older will take alcohol and go to sleep. So no movements, and alcohol causes dehydration. So he actually or she ends up at more risk. So even if somebody has any alcohol, it should be moderate and it should be enough fluids after that so that you have to go to the washroom so that you mobilize. And also here is a case for wearing stockings, correct fitting stockings you may wear for travel, which are not ill-fitting. It should not become like a tunic. Okay, so, and I will tell them, okay, every 1 hour, get up and walk a little bit, And some people who are cardiac people, ask the cardiologist and with them or a hematologist, put them on, 75 milligram of aspirin or clopidogrel if there's no bleeding risk, and keep them on it for 1 week after landing. The risk remains for 1 week after landing, after long travel. And the risk starts after any 4 to 6 hours travel. By road, by bus, by car is the worst. Because when your knees are flexed and you're sitting in the back seats, your knees flexed, your drainage becomes that much difficult. It's gone from the distal popliteal to the femoral, there's a flexed knee. It has to go through that. So there's stasis in the distal limbs. So you must stretch your legs, do dorsiflexion of the ankle so that the calf muscles work. When the calf muscles work, the peripheral heart works and blood is pushed up. So those are very practical because today's world, everybody's traveling all the time. Okay, Dr. Manthan again, should we monitor the activity DOACs when given a patient with renal impairment? Yes. I told you more than DOACs, I will monitor the renal parameters. I told you the GFR should be more than 30. So the creat, if it's rising due to whatever reason, either the disease or the drugs you're giving, I told you if the DOAC becomes less than 30, goes to 20, your DOAC has to be stopped. So monitoring is one, but creat clearance is important. So very frequent, and sometimes even in the first critical phase of 7 to 14 days, we do daily. We do the renal parameters daily. So I think it's very important for us to do that. And as a matter of fact, I think we must be careful, but we will monitor the renal parameters all through. Okay. Okay. Yes, I see my good friend General PP Verma there. Okay, good. I can't make you unmute because I don't have the pass, but you can put any questions, General PP Verma, sir. Please welcome. You put on the chat box. Yeah, good evening. Good evening. You can put your question in the chat box. If there are any questions which will help our students. So I think, like I said, bleeding gets the patient to the hospital because, whether it's hematuria, bleeding PV, bleeding from the oral cavity or from a trauma, you will reach a hospital. But venous thromboembolism is a silent killer. And if you don't know where to look, you don't have a clinical suspicion, I told you 2/3 will be missed. And if it's silent, you can add it to the silent killer list. That's what happens. All hypertensive don't have symptoms. 1/5 have symptoms. The rest can have high BPs and go around doing everything, suddenly have a cerebral hemorrhage. So venous thromboembolism, you can add that to the list. And with what our practice is, with people living longer, people getting more cancer, using chemotherapy, using iatrogenic equipments, dialysis, central catheters, and chemotherapies are all going to get you more thrombotic episodes. So I really think a high index of suspicion and all our MDs, MSs, DNBs, DMs, DRNBs must join this gang of people who have a high index of suspicion. And teach your paramedics, teach your nursing people, and your public health people must be brought on board. In the public guidelines we have given the ministry, we have said how to involve the public health people from the primary health center onwards to the Apex hospital in a private or public. Okay, if there are no other questions, it's 7:35 and I am happy. I have covered all aspects that I think are important. I've covered what I could not cover. And I think we can give them 20 minutes off. Dr. Kapil and Dr. Sood and Preeti.
Right. Sir, we can close the session, sir. Dr. Preeti, please.
Thank you, sir. I would like to invite Professor Ajay Kumar Sood, sir, to provide the vote of thanks.
Once again, it is my great privilege to thank on behalf of National Academy of Medical Sciences, Lieutenant General Velu Nair, sir, for his excellent, I think, lecture. And I'm sure this combination of eminent clinician, researcher, and a wonderful teacher, I think it is very rare to find. All of us have enjoyed this session. You have covered right from the historical perspective to the recent advances. And you have again given very important tips to our students, whether they are surgeon, whether they're in the cancer department, or whether they are even for support worker. You have said that nursing officer and health officers who are working at the PSC level. I think very comprehensive presentation, and congratulations to you, sir. And I'm sure that our students have greatly benefited from that. So once again, sir, we look forward to your continued support and blessing to the board for the academic activities and other support. Thank you so much, sir. And I will also like to request Dr. Kapil, who is there, if you'd like to add something, sir.
So you are on mute.
Dr. Velu Nair is a legend in the field of hemato-oncology, and under his chairpersonship, we had a task force and that has been released by the Ministry of Health and Family Welfare. And it's a great honor and privilege to be associated with Dr. NAMS being associated with Dr. Velu Nair. We are most grateful to you, sir. Thank you very much.
Thank you, sir.
Thank you very much, NAMS. Thank you, Professor Kapil. Thank you, Professor Sood and Preeti, for the wonderful support. And I really enjoyed, and I was delighted to be here. Thank you all the students for joining us. Jai Hind.
Jai Hind. Thank you, sir. And just for the information of the students that please note that the next session is on 6th of June, which is Tuesday. As Sir said, it is very important session on thrombocytopenia, especially those who are working in ICU and the critical area. So please do inform your friends to join this session. So I will also like to mention that in the month of June, we are going to complete the theme of psychiatry. There are 4 sessions which are due, and there are 2 wonderful, very important sessions on diabetes, but by Dr. V. Mohan. So I think he is going to take this session on 20th and 27th of June. So all of you must at least, these are very important sessions and very eminent speakers who are going to be with there. So kindly take best use of these opportunities. And with these words, I would like to thank Dr. Preeti, my colleague here, for wonderful way she has been coordinating and support which has been provided by our IT team. I can now see Mr. Ravi and Mr. Anil. Thank you so much. You have come on a holiday to the NAM's office and done that. So with these words, once again, thank you all and Jai Hind, sir.
Thank you, sir. And thank you all. I declare today's academic session closed. Thank you.